We're going to move now into the earlier phases of disease, and Jason Efstathiou is going to introduce that subject, specifically the proton therapy issue.
Great. So it truly has been a marathon of very, very elegant talks. Thank you. And so I'm very honored to be invited to talk here by Bruce and by the STO. So I'm going to give a little bit of a whirlwind talk of localized prostate cancer and clinical trial data in that, and sort of focus and highlight on some evidence supporting dose escalation, radiation therapy, review some of the current state-of-the-art technologies that we employ, and also kind of focus on the physical and clinical potentials of proton therapy specifically and its associated uncertainties. So let's start with the U.S. healthcare system, because this is where it all fits in. The healthcare systems are not created in a vacuum. They reflect the underlying values, tolerances, expectations, and cultures of the people they serve. Then we can go to a spaghetti western, the good, the bad, and the ugly. And in the words of Blondie, in this world there are two kinds of people, my friend, those with loaded guns and those who dig. There are also two types of economies in this world. Those that sit on piles of cash and those that drown in a mountain of debt. And we may argue that the U.S. is entering the latter category. And some have even made the prediction that Medicare may go bust in the not all too distant future. So we have to come back and look at the physician charter, who we are and what we do. So it says the conditions of medical practice are tempting physicians to abandon their commitment to the primacy of patient welfare. There are 3 principles as listed here and 10 commitments, including the commitment to a just distribution of finite resources. Physicians are required to provide healthcare that is based on the wise and cost-effective management of limited clinical resources and the avoidance of superfluous tests and procedures. And the provision of unnecessary services not only exposes one's patients to avoidable harm and expense, but also diminishes the resources available for others. If we don't address this proactively, others will. My field has been the subject of many New York Times headlines in the last year or so, as you can see here. In fact, the writer for the journalist has already won a Pulitzer Prize, I believe, for bringing down the American tobacco industry. So when we're in this crosshair, we get a little worried. So, given that, and given that we have to figure out the comparative value of what we do, there are some countries that are embracing this and forming panels and agencies, like in the UK, the NHS has developed the National Institute for Clinical Excellence and Health, otherwise known as NICE. Sounds very nice. In the US, we have our counterpart, the Federal Coordinating Council for Clinical Effectiveness Research. And this is managing money from the Recovery Act of 2009, and I will not enunciate this acronym. So where does prostate cancer fit into all of this? We know this curve. It's common. It's a common disease, very prevalent, high incidence rates, though mortality rates have largely not budged. So the risk of a U.S. male having prostate cancer, sorry for the little mess up on this slide, with aggressive screening, so prostate biopsies, is over 25%. Though the risk of dying from prostate cancer really doesn't seem to budge, and this comes from the prostate cancer prevention trial. We also know that there's a lead time bias with PSA screening on the order of about 7 years. So let's look at one of the landmark studies in localized disease. This is the Scandinavian trial of radical prostatectomy versus watchful waiting. One of the reasons we say we should treat localized disease. It was done in the pre-PSA screening era by and large. And so let's look at the results. Well, it took a while to show a difference, but it showed a modest survival benefit to radical prostatectomy versus surveillance. But now let's add in those 7 years. And you can see that it really takes a long time to realize that benefit. So active surveillance. We have great data. This is Lori Klotz's data suggesting cause-specific survival of 99% in appropriately selected patients. So why aren't we doing that more? So who needs screening and who needs treatment? It's an important question. Let's look at what contemporary U.S. practice tells us. So this was a national questionnaire that was given to about 500 radiation oncologists and 500 urologists. Radiation oncologists recommended, 43% of radiation oncologists recommended PSA screening for men aged 80 or older. This was published in JAMA. Florida, much more enthusiastic state, and for a variety of reasons. Urologists were actually much more reasonable, but still quite a good percentage recommending, especially in Florida, the use of PSA screening in very elderly patients. So now let's look at what U.S. practice of patterns tells us. Well, it tells us that in localized disease, external beam radiation is used about 12% of the time. Radical prostatectomy, 50% of the time. This comes from a big urologic database in California, the CaPSURE database. So now let's look at that a little closer. For all intents and purposes, this is low risk, intermediate, high risk disease. What's going on here in low risk disease? Well, look at how many. The blue is radical prostatectomy. How many are getting radical prostatectomy, and how infrequently active surveillance is actually being utilized in a contemporary registry. There's another point actually here. Let's look in, and this is time going on, so 1990 up to 2007. Let's look at high-risk disease. What has happened to the red? The red is external beam radiation. It's in fact gone down in use in high-risk disease over the years, and what's increased? Primary androgen deprivation therapy. I would argue that this pattern of practice is not evidence-based practice, and I'll show you the data to explain that. Fortunately, we're being helped by the UK, and in many circumstances, the US is helped by socialized healthcare systems that can actually run practice-defining trials. This is the PROTECT study, one of the, what I would call, trials of the century in localized prostate cancer. 250,000 men accrued in 6 years at general practice, family practice in the UK, randomized to PSA screening or not. That's incredible, would never happen here. Amongst intermediate and low-risk patients that were case detected in the PSA screening portion, they were randomized to surgery, external beam, and active surveillance. So in fact, preliminary results from this trial will be in 2015, so answers are coming to important questions. But in patients who need treatment, does radiation work? The surgeons had that Scandinavian study. Radiation actually didn't until relatively recently, but thanks again to Scandinavians, now we do. So this is Widmark, who published in the Lancet in 2009, locally advanced or high-risk prostate cancer receiving randomized to either hormonal therapy alone or external beam radiation plus hormonal therapy. And what did we see? Whopping benefits in terms of decreasing risk of PSA recurrence, and very clear and significant survival gains with actually no quality of life disadvantage. So radiation works in patients that actually need treatment. So what is driving treatment? Well, in some cases we believe we can save lives, and that data suggests that in certain circumstances we do. We also like to reduce the risk of local and distant progression, obviously, to reduce the risk of androgen deprivation therapy, or some of the other very elegant agents that were described today. We like to lower the PSA. That's something that's sort of guttural, makes us feel good. And the word cancer, of course, has stigma associated with it. It has led some to call prostate cancer, low-risk prostate cancer, prostatic neoplasia of uncertain tumorigenic significance. And the acronym for that is PNUTS. But there's another reason why we're driving treatment. It's our addiction to technology. We really are, as people, as addicted to technology. I'm sure many have iPads, phones, little Mac Airs right here, right now. So there's this state of gizmo idolatry, the sense that gizmos have a common sense appeal. The humans love bells and whistles. We think gizmos are heroic exploits. The smaller the better, the faster the better. Gizmos can minimize risk. They are proof of competence, and they are also a revenue source. So here is the radiation oncologist's tool, the linear accelerator. It actually brings up a very interesting American author and social critic, Neil Postman, who has described 3 ages of civilization. The tool age, where tools solved simple problems. Then technocracy, where tools were used to solve problems and increase understanding. They were actually instruments of progress and power. And now he might argue that we enter a state of technopoly, or a submission of life and thought to science, where technology in fact shapes our thinking. So technology is a state of culture and a state of mind. It consists of the deification of technology, which means that the culture seeks its authorization in technology, seeks its satisfaction in technology, and takes its orders from technology. Technology defines the questions we ask and the work we do. This doesn't just apply to radiation oncology. So this was radiation oncology 1991 with conventional orthogonal films here, conventional external beam radiation. Boom, 2011. We have conformal 3D IMRT proton SBRT, CyberKnife, high-dose conformal brachytherapy, brachy plus external beam, and all of the above with hormonal therapy. How did it come to this? Well, there was a legitimate reason. There was a local tumor control problem with radiation therapy in prostate cancer. So if we look at this data from 9 U.S. centers, early stage tumors, that's horrible. We have to definitely do better than that as far as PSA progression and PSA failure. So what was our solution in radiation oncology? It was to increase the radiation dose. Simple enough. And fortunately, we are informed by at least 4 randomized phase 3 studies. There are at least 4, in fact 5, good dose escalation studies that inform us. Take-home message, there's a 10 to 20% benefit in freedom from biochemical failure with an 8 to 10 gray increase in total dose. So a very nice study from MD Anderson and MGH leading the PROG study along with Loma Linda, others coming from Europe. And here is the MGH PROG data that was recently updated with long-term follow-up showing significant freedom from PSA failure with higher doses of radiation. So level 1 evidence supporting that use. In fact, now asking the question in intermediate risk prostate cancer where it's customary to add in a short course of hormonal therapy, do we in fact need to? So this is an ongoing trial that's accruing as we speak. So what is the toxicity? There are costs to what we do. What's the toxicity associated with dose escalation? So from Anthony Zeitman's dose escalation trial, if we look at late grade 3 GU toxicity in the low and high dose arms, they're the same and rather similar for late GI toxicity. So we think we can get away with this dose escalation without major costs. In fact, there was a companion quality of life study. To bring up Marty's point earlier, you have to study patient-reported outcomes. In just about everything we do, we should. And so we looked at, in Anthony's study, Jim Talcott looked at the question, and again, here what you'll see is basically patient-reported outcomes were the same in the low and high-dose arms as in terms of urinary symptoms, bowel symptoms, and rates of impotence. So there's another problem, though, with dose escalation. Higher doses need more accurate delivery. So there's been hardware and software advances in radiation, better prostate imaging. Here is the 2D radiation of the 70s to the 90s, 4-field box that some of us may be used to. 1990s, CT planning was introduced. We used beams of different angles. By 2000, we're using something called intensity-modulated radiation therapy with inhomogeneous beams sculpting around the target and avoiding normal structures like the rectum. And that translated into a significant, what we call dosimetric benefit. These are dose volume histograms. The amount of rectum receiving 70 gray or more. This is 2D radiation, 55%. 3D, 30% with IMRT, less than 20%. However, you have to remember that a physical advantage, a dosimetric dose distribution advantage does not necessarily translate into a net health outcome advantage. And so we are really only informed by one randomized trial between these technologies. This is 2D versus 3D radiation showing a benefit to 3D over 2D. So as we've climbed this ladder from 2D to 3D, we have level 1 evidence supporting it. But we're using IMRT and protons now at much greater expense. Do we have the level of evidence to support its use? Some single institutions, like Memorial Sloan Kettering, would argue a benefit to IMRT over 3D as far as rectal toxicity. A SEER analysis on bowel outcomes. This is a very significant p-value, but not a significant curve. I mean, this is a modest benefit of IMRT to 3D as far as bowel outcomes, which is thought to be the most sensitive outcome to measure after radiation therapy. So when you're looking at 3D versus IMRT, there's a presumed clinical benefit for patients, but it's been a windfall for physicians and their hospitals. So I want you to look close at this. This is a true advertisement from what's called UroRad. UroRad are urology-owned private practice radiation facilities that have been opened up. They're in a matter of major national debate as far as self-referral now, because if you look at the regions where these centers have opened, the urologists no longer perform radical prostatectomy, they're getting IMRT. And so when Lupron started to decrease its compensation, this is the ad that came out. Double your practice revenue with a UroRad prostate IMRT center of excellence. And they said that IMRT has the sharpness of a surgeon's knife and the softness of an artist's brush. So this is what's happened to IMRT utilization versus 3D conformal radiation. It's exploded. And this is also not showing, but this is actually the CPT billing code showing an explosion, currently over $1 billion annually in IMRT treatment delivery and planning costs. And even in addition to all that, this actually should show a prostate that's moving around. So it's argued for image-guided radiation therapy. And so in addition to these other technological advancements, we've introduced things like daily ultrasound, daily CAT scans. We've introduced fiducial markers into the prostate imaging to target and localize as we've become more and more conformal in our treatment delivery. And in fact, now we have smart transponders, smart fiducials. These are GPS tracking devices implanted into your prostate so that your prostate is followed during treatment. So, and now, Proton Beam. So the aims of Proton Beam have been a promise of better tumor eradication through higher doses and reduced morbidity. There is, so let me just show you. This is the premise of the promise of proton therapy is built on this curve, which is called the Bragg peak, which shows that the majority of energy with proton therapy is delivered at a prescribed depth in the body, and then there is no exit dose. So you are saving yourself cumulative dose at entrance and at exit with proton beam over photons. So is it really a searchlight without a tail? Is it that simple? Well, there is a clinical potential for this. And here is a great example. This is pediatric medulloblastoma. This is treated with photons. Look at all the dose received by anterior organs. So these are the heart, the lung, the bowel, etc. Look at protons. Pretty. They stop. The Bragg peak makes them stop. Here's an axial slice. The heart getting hit with photons, not getting hit with protons. You do not need a randomized trial to say that this is superior treatment for a 3-year-old child with medulloblastoma requiring craniospinal irradiation. In a sense, a picture is worth 1,000 words. But here is prostate. So this is proton delivery, 2 lateral beams versus 7-field IMRT. Is there really a difference here? Well, if you minus out the IMRT plan from the proton plan, this is what you get. The prostate gets treated to the same dose. There's no higher cure rates with proton therapy. With the prostate, the target's getting the same dose. But there is this low-dose bath over a larger region of the pelvis with IMRT. Does that translate into higher fatigue levels, higher proctitis levels down here? Does it translate into higher rates of second cancers related to radiation exposure in the long run? We don't know. But in fact, we're moving on without answering that question. We're now developing IMPT, intensity modulated proton therapy. And here's how these things compare. So if we look at this DVH, we'll see the comparison between IMRT, 3D, or regular protons, and IMPT. High dose about the same, but there's this low dose advantage to these proton technologies. And in fact, we're developing other ways of delivering it here with our smart physicists here at MGH of anterior beams coming in, avoiding the hips and less tissue. You've got to be careful not to overshoot as you're shooting into the rectum. So, protons. What's the promise of protons? Can we deliver higher doses with proton therapy compared to other technologies? Well, we've looked at that question. We delivered 82 gray using just protons alone, and we felt that we're starting to hit the ceiling on grade 3 or higher toxicity levels. So we think that there is a ceiling that's going to be hit no matter what technology is used. Can we deliver higher focal doses to the prostate, meaning sort of focal therapy? So maybe this picture shows it best. Sort of, let's say 70 gray to the whole prostate, 79 just avoiding where the rectum is here a little bit, and then 90 or 100 gray to where a tumor nodule is found on MRI imaging or whatever other tools we have available to us. Well, we've done planning studies and we say, yeah, we could actually do that. This is not in practice yet. But there's uncertainty with protons that folks should be aware of who are not radiation oncologists. There is what we call end-of-range uncertainty, meaning the beam is not as sharp the deeper you go into the body, and the prostate is about as deep you can go in the male body, in the pelvis. And so this sharpness gets lost a little bit. Similarly, if I took out these angles, you probably wouldn't be able to tell that the femoral head here is angled slightly differently in these two snapshots. But that actually affects dose delivery if you're shooting through with lateral beams, and distortion in the delivered dose with proton therapy. So there's sensitivity to tissue heterogeneity, thickness of bone, etc. So proton therapy is great. I mean, you can deliver high doses, it's highly conformal, but the beam is not so sharp at prostate depth, and it's very sensitive to bone density. So is proton therapy really an improved means to an unimproved end? So if we've gone from IMRT to proton beam now to IMPT, is there any proven advantage to this? And I would answer that despite the theoretical advantages of proton therapy, studies have yet to show any clear clinical benefit to proton therapy compared to IMRT, largely because good studies have not been done. And also because, look, you're not going to avoid the urethra and the anterior rectum and the bladder neck that are touching basically the prostate. This is where most of the toxicity, definitely acute toxicity, comes from. And we've also shown through a series of different trials that we can deliver a high-dose radiation using 3D IMRT and proton therapy, or proton therapy. So we can probably do it with a variety of technologies. So there are two explanations for this. Either we've looked for the advantage in the wrong way, or there is no clinically significant advantage. And this leads into the last part of this talk, which is the business model. So here is a pretty picture of the gantry, one of our gantries at the Francis Burr Proton Center here at MGH. The current cost to build a facility like this is probably on the order of $150 million, perhaps upwards towards $200 million. So if you look at a map of the US, there are, well, actually there are 8 now, though there's 7 stars there, 8 functional proton facilities within the US. And many more are being planned. Now, that's Oklahoma. And there are 2 centers that are going to be probably within half an hour drive from one another. And in New Jersey has a academic hospital and a private practice building a full cyclotron, a matter of about 15-minute drive from one another. So there's a debt to be paid back. And the debt depends on reimbursement, it depends on your patient mix, and it depends on the terms of your loan. So there'll be pressure to reduce costs, simplification of therapy, leaving out upgrades, stuck with prototype machines, avoid treating those most in need. Who would you rather treat if you had to pay back a debt on a proton facility? Pediatric medulloblastoma requires general anesthesia and about an hour to an hour and a half treatment time. So there is classic market behavior, which is supply and demand. Then there's the European or socialized medical market behavior of technology, therapy, evaluation, and then regulated supply. And then there is US medical market behavior, which is supply-led demand, code-driven supply, and advocacy-led demand. And this is proton therapy. It's all over the news. This is Proton Bob. A couple of issues of Men's Health ago had a 5-page expose on proton therapy. It is everywhere here. And a number of cost-effectiveness studies have suggested that this is not a cost-effective treatment necessarily for localized prostate cancer, including the MGH Institute for Clinical and Economic Review. So what is the future of all this new technology? The adoption and dissemination of unproven emerging technology in healthcare delivery has risks of distorting patterns of healthcare, has risks of paradoxically leading to over-treatment of patients, maybe active surveillance would have been better, sucking resources from areas of medical need, perhaps driving some institutions' practices to financial ruin, and drawing attention to and discrediting uro-oncology. I did not say radiation oncology. We're all in this together. And this technology does not just apply to my field. So here's the new technology curve, an enthusiasm curve. Celebrities treated, then it's thought to be the best thing since sliced bread. Then you wouldn't give it to a dog, and then you finally figure out appropriate use. What we need to do is inform appropriate use and limit the peaks and troughs in the acceptance and adoption of new, promising, and potentially expensive technology. And this includes drugs, all the drugs. I would suggest that sibuleucel T may not be accepted in some countries, such as Canada or the UK, or may not be proven therapies. So it applies to all of us. There's regulation that happens. I'm going to argue for coverage with evidence development. I don't believe in rationing these types of technologies. I think that there should be coverage with appropriateness determination and also studies and financing of studies studying technology. And to that end, I'll just show that we've partnered with the University of Pennsylvania and MGH to run a randomized trial in low intermediate risk prostate cancer, IMRT versus Proton Beam, with patient-reported quality of life primary endpoints. And similarly, we've gone through all of this today. Bench research will tell you what happens. Prospective trials like the RCT I just mentioned tells you what should happen. And then we need observational studies that tells us what does happen and what will happen. And to that end, we are developing, with the support from MGH-NCI Federal Share Program, a national radiation oncology registry with prostate cancer as the pilot, linking institutions electronically and collecting patient-reported quality of life endpoints. There is also the possibility that all this technology is going to, in fact, lower treatment costs. And so I'll just point out what's called hypofractionation, or delivering fewer larger treatments, increasing patient convenience and lowering treatment costs. And so a number of randomized trials looking at 4 or 5 weeks instead of 8 weeks are going on now. And then the question is, well, how low can you go? And a number of studies using what's called stereotactic body radiation therapy, 5 treatments versus, for example, in this phase 2 study, 12 treatments in low-risk prostate cancer being run by the RTOG, where Proton Beam is allowed. And then, of course, highlighting some of the talks earlier, we've got to figure out which individuals best benefit from technology as well. Perhaps there are subgroups that benefit from one technology over another. So this is last few slides in conclusion. The U.S., I believe, needs proton therapy. Ideally, it's geographically well distributed. There's consortia based around academic centers, heavy emphasis on pediatric cancers, heavy emphasis on research, including in prostate cancer. Proton Beam is an excellent treatment for prostate cancer, but so is radical prostatectomy, 3D conformal IMRT brachy and active surveillance. And here is the new is not always better, the law of diminishing returns. And again, it's not just unique to radiation oncology. This applies to all our fields. So finally, prostate cancer is an overtreated disease. We know that, localized in a variety of ways. And we have to figure out who needs treatment and who doesn't. And external beam radiation, however, is a safe and effective treatment, and dose escalation improves cancer control. Very strong evidence to support that. Technology is great, but it's seductive and it can be expensive. It can be used creatively to increase dose and dose per fraction, account for motion, localize and boost a tumor, reduce overall treatment time. Like I said, maybe we can get away with 5 treatments instead of 8 or 9 weeks. But it can also be equally creatively used to increase billing and income boosting. So if all forms of high-dose radiation are comparably efficacious, then we really need good quality of life and economic analyses to determine their true justification and appropriate use. We have to also look beyond technology into the biology, as has been highlighted by the elegant talks earlier today. And I'm going to leave you with this quote from Ezekiel Emanuel, who is the brother of the current mayor of Chicago. He is also a bioethicist at the NIH and a medical oncologist who has said, novelty cannot be equated with benefit, and intervention's value resides in its ability to reduce mortality, morbidity, or save money, not in its unique mechanism of action. Thanks very much.